So I'm going to talk a little bit about just in general MS, and then we're going to talk about how MS differs in kids compared to our adult population. And then I'll talk some about how in kids who are presenting with an acute demyelinating syndrome, so a one-time event, how can we determine if this is truly a one-time event, or is it a disease that may go on to have a relapse and reveal itself as multiple sclerosis? So what is multiple sclerosis? It's a chronic recurrent autoimmune disease affecting the central nervous system. And so it is characterized by immune cells. Let me grab the other pointer here. By immune cells that will attack this myelin or insulation of the nerves and causes demyelination and to a lesser extent axonal damage. So there are 4 types of multiple sclerosis, and by far the most common type is relapsing remitting multiple sclerosis, and in kids this accounts for about 90% of MS. And these are characterized by attacks of new neurologic symptoms that will occur over the course of usually days to weeks, and then the symptoms will remit and they return either back to their baseline or usually close to their baseline, and the disease may remain dormant for several weeks or months, and then they'll have another attack come on later on. There's also secondary progressive MS, and so this is in some patients who start out with relapsing remitting MS, that they may go on to develop secondary progressive MS, in which over the course of many years, if they begin to accumulate some progressive symptoms over time, even without clear relapses. We know in the pediatric literature that this tends to happen later on in the disease course. So in adults, we see this after about 10 years. About half of people with MS will go on to develop secondary progressive. But in children, it looks like it's over 20 years out from the disease. And then we have primary progressive MS, where they're having progressive symptoms from the onset of disease. And this is really very rare in kids. In adults, it accounts for about 10% of cases, but in kids, it's probably more like 3 to 4%. And it really should raise a red flag to your diagnosis if you're seeing progressive symptoms in kids from onset. So this is showing us the geographic distribution. We know that the northern latitudes in the United States and Canada and European countries, that there's a higher prevalence of MS there. And a little bit later I'll talk about the role of vitamin D in MS, and there's a thought that this is contributing to that geographic distribution that we see. So a little bit about MS in general. So overall, MS occurs in about 1 per 1,000 patients. We have about 400,000 people in the United States who are diagnosed with MS, and we typically think of it occurring in young females, but we're increasingly realizing that this also occurs in kids and that there are some distinct differences between the 2 populations. So some people believe that MS in childhood may have some distinct differences than what we see in adults because the kids are still undergoing myelination. And so pediatric MS really offers a unique opportunity for us to study and learn more about MS because these kids are unique in that they're presenting very close to the true biologic onset of the disease. So pediatric MS, we see that up to 10% of all cases of MS occur in kids, people who are less than 18 years old. We have about 10 to 30,000 cases of pediatric MS in the United States alone. Most of the kids with MS will have their first attack between the ages of 9 and 13 years. In the adults, we know that that MS is much more common in females compared to males, but we really don't see quite the same ratio in kids. So in kids who are less than 6 years old, they have a very similar sex distribution. But as we get up to over 6 years, we start to see some of that differentiation between the sexes. And when we start to get up to our teenage years, it starts to become close to what we see in the adult population. So this is taken from a meta-analysis of over 1,500 pediatric MS patients. And so they looked at some of the clinical features. About 96% of these patients have relapsing remitting type MS. The primary progressive type was extremely rare. It accounted for about 3% of patients. They found that 17% of these kids presented at less than 10 years of age at their onset. And they also found that the majority of kids, they presented with multiple symptoms and had multiple areas affected with their initial inciting event. The symptoms at onset, so a little bit of difference here than what we see in adults. So optic neuritis and sensory symptoms are less commonly reported as a first event in children. And part of this may be that in mild cases that it's probably difficult to recognize these symptoms in kids. Another point is that transverse myelitis is uncommonly a first event for MS. So only 10% of MS cases will have an initial event of transverse myelitis. And then some of the symptomatic issues, so we see about 40% of kids will have fatigue at some point, and that's probably actually a low number compared to what we see in clinic. And over 30% will have some type of cognitive dysfunction associated with their MS. So this data is taken from a review article that was published by the International Pediatric Study Group. And so they found that overall that kids tend to have less progressive disease, that they had lower disability scores. They found that the median time that it took to reach an EDSS of 4, so this would be someone who is ambulating without assistance, but they do have some severe deficits in at least one category on their disability scale, that in kids it took about 20 years to reach that level, whereas compared to adults it was about 10 years. They also found that there were more frequent relapses in children compared to what we see in MS. So about 60% of kids with MS will have a relapse within their first year. They also found that the relapse rate was higher in kids compared to adults. So in kids, about 1 per year early on in the disease as compared to adults who now in the more recent trials we're seeing about 1 every 2 to 3 years. Their relapses tended to remit more quickly and more completely. So in kids, the typical relapse lasted for about 4.3 weeks. Compared to adults, it was between 6 to 8 weeks. And then I mentioned earlier their time to conversion to secondary progressive MS was longer, but it did occur at an earlier age because of the early onset of disease. So this study is looking at 110 adults and 21 kids who are newly diagnosed with MS, and they found that they had a slower initial disease progression, but they did find an increased relapse rate. So overall, the annualized relapse rate in this group was 1.4 in the kids compared to 0.65 in the adult population. And they also of note in this study, there was no child who at the inciting first event, so in our clinically isolated syndrome, that was actually treated with disease-modifying therapy in this group. And so there was a difference in terms of duration of therapy that, between the adult and pediatric group here. But even when they tried to decipher that out, so they looked at pre-treatment relapse rate compared to post-treatment, they still found that the relapse rate was higher in the kids. So how do we diagnose MS in kids? So we've talked a little bit about some of these diseases already this morning. So when a person comes in with a first attack of demyelination, we have to try to decipher out, is this a one-time event, something like acute disseminated encephalomyelitis? Is it a focal event like a optic neuritis or transverse myelitis? Or are they likely to go on to have a disease like multiple sclerosis? And so we can get some clues from the examination. For example, people who present with encephalopathy, classically associated with ADEM, are less likely to progress to MS. We can also get some clues from some MRI markers that I'll talk about a little bit more. And then some of the spinal fluid, the CSF studies, help us to make that distinction as well. So acute demyelinating syndrome. So these are kids who are presenting with the first attack. And so there's been many studies looking at these events. So a couple of them, this group from France, KIDMA study, they looked at 296 children who had a first inciting event, and they found that overall 57% of them were eventually diagnosed with multiple sclerosis. And we're going to talk a little bit more about this study in a couple of slides. Another study looking at a prospective study of 36 kids who presented with optic neuritis, they found that 36% of them developed MS, But they also found that in patients who had a completely normal MRI scan in this group, that none of them went on to develop MS. So how can we predict who's at risk? So this is taken from the current opinion in neurology from last year, and so they looked at what are some factors that we can use. So associated with the increased risk of relapse, you have kids who are less than 10 years, who are older than 10 years of age, tend to have an increased risk compared to those who are younger. People presenting with a clinically isolated syndrome type criteria compared to the ADEM group is more likely to go on to have MS. Optic neuritis was more commonly associated with relapses in the future compared with people who presented with isolated transverse myelitis. Encephalopathy was associated with a higher risk and a lower risk, and people who presented with a preceding infection were less likely to go on to have risk in of relapse in the future. MRI criteria, so MRIs that were suggestive of MS at the onset of the first inciting event had an increased risk, and then also findings on the CSF also suggested risk of relapse. So this is taken again from that group in France, the KIDMES study group, and so they looked at 296 children who had a first inciting event, and this is just comparing the numbers here. So you had at initial diagnosis, multiple sclerosis was diagnosed, or ADEM, or a single focal episode like transverse myelitis or optic neuritis. And then they followed these kids out for an average of about 3 years and looked at what was the final diagnosis in the end. And so in the group who were initially diagnosed with ADEM, 29% of them eventually went on to have a diagnosis of multiple sclerosis. Also of note, if you look at this number, the group of patients that were eventually diagnosed with multiple sclerosis, only 5% of these kids here had an initial presentation with a focal episode, so like a transverse myelitis or optic neuritis. This is taken from the same paper, and so this is looking at the proportion of patients who are relapse-free over the course that they followed the kids here, and they're dividing it out into their initial diagnosis. And they found that the median time to a second attack was about 1 year for the patients that were initially diagnosed with multiple sclerosis, compared to 4 years for those who were initially diagnosed with acute disseminated encephalomyelitis. The second chart here is, again, looking at the proportion of patients that are relapse-free, but they're looking at the difference in the age of onset. So they found that kids who were greater than 10 years of age were more likely to go on to have a second relapse, and that happened sooner in this group. They also looked at a few factors that were predictive of recurrence, and they found that an age greater than 10 years, and also MRI that was suggestive of MS at onset, and an optic nerve lesion was associated with increased risk of recurrence in the future. So how can we use MRI to help us make the distinction of MS in the pediatric group? So MRI appearance, there has been differences reported in MRIs in kids versus adults, such as there's been increased number of these large, what we call tumefactive lesions in children. There's also been a decreased number of enhancing lesions seen in MRIs for kids. For adults, we use the McDonald criteria to help us make an earlier diagnosis of MS, but these criteria have been evaluated in various pediatric cohorts, and they really don't seem to have that very good sensitivity or specificity for the children. There's several reasons as to why some of the appearance on MRI may differ. So some people believe that the duration of disease is different in the kids, that your maturity of the myelin is different, the immunologic maturity, and the capacity for myelin repair is different in kids, and so this may account for some of the differences that we're seeing. So there's been a couple of proposed MRI criteria in the pediatric group. So this one was proposed by the KIDMES study group. It looked at 116 kids who had a first event of demyelination, and they found two criteria that they thought were most predictive. Lesions that were perpendicular to the corpus callosum, so the connector between the two hemispheres, and the sole presence of well-defined lesions were associated with a higher risk of recurrence. They compared their criteria to the Barkov to the McDonald criteria, and they found that actually the McDonald criteria was more sensitive in their group, but it was less specific at predicting recurrence. They also divided this out and looked at kids who were younger than 10 years of age, and they found that both of these sets of criteria were actually pretty poor predictors of recurrence in the youngest kids. So another proposed criteria was set forth by Callan in this paper, and they did a retrospective analysis of 38 children who had clinically definite MS, compared it with 45 children who had some type of other neurologic disease. And they found that the presence of at least 2 of the following: 5 or more lesions, 2 or more periventricular lesions, and 1 brainstem lesion was predictive of recurrence. And these criteria were also compared with the McDonald criteria and with the KidMIS criteria, and they found that they were more sensitive. They had a sensitivity of 85% in their group of patients. So the same group also looked at the role of MRI in distinguishing between MS and acute disseminated encephalomyelitis. And they found that any 2 of the following was predictive of multiple sclerosis: 2 or more periventricular lesions, the presence of black holes indicating axonal damage on the initial MRI scan, and the lack of bilateral diffuse lesion pattern that we typically associate with ADEM. These were predictive of multiple sclerosis with a sensitivity of 81% and very good specificity of 95%. They also looked at localization of lesions to try to see if they could find a distinction between lesions in ADEM versus multiple sclerosis, and they really did not find any differences except for in the periventricular white matter lesions, that these were more common with the MS group. But the other locations here were really not statistically significant. So this is just a comparison of the criteria that we mentioned, a review of the different criteria, and then just to draw a note to this last group here really is used to distinguish between MS and ADEM, whereas the other ones are looking more at how, in someone presenting with a one-time acute episode, how can we go on to predict the risk of recurrence for them. So I'm just going to talk about a couple of risk factors that have been pretty hot in the literature lately, one of which is vitamin D. So this is a retrospective study that was performed from UCSF and SUNY, and it looked at 110 kids with both multiple sclerosis and clinically isolated syndrome. And they found that, and they measured their vitamin D levels and adjusted them for seasonal variations. They first of all found that the baseline level was 22 nanograms per milliliter, so only 15% of the kids in this group actually had a normal vitamin D level. And then they also found that for every 10 nanogram per milliliter increase in their vitamin D level, that there was a 34% decrease in the risk of relapse. Another look at vitamin D, and this is taken from the adult literature. This looked at 7 million military personnel, and they found 257 cases of multiple sclerosis, and they looked at their vitamin D levels prior to symptom onset. And they found that amongst Caucasians that there was a 41% decreased risk of MS and for every 50 nanomole per liter increase in vitamin D. So this is a little bit different measure than what I was talking about before, but this would be equivalent to about 20 nanograms per ml from the last slide. They also found that with this graph is looking at, so they found that they divided up the vitamin D levels into different groups, and they found a significant trend of decreased risk as we went higher in terms of the vitamin D level. And then they also found that there was a 51% reduction in the risk of MS in patients who had levels greater than 100. Overall, they also found that African Americans and Hispanics tended to have lower baseline levels of vitamin D, too. So another big topic is smoking. So there's a lot of literature on the adult side in terms of smoking being associated with the increased risk of relapse and increased progression of disease. But this is actually looking at some of our pediatric patients, and they looked at exposure to parental smoking, and it looked at 129 cases of MS, and then they had over 1,000 controls in the study. And they found that there was a 2-time greater risk of developing MS in those kids that were exposed to smoking at home. And the risk of MS was certainly greater in those who had a longer duration of exposure. So what are some of the treatments for pediatric MS? So there's currently, as of earlier this week now, 8 FDA-approved medications for MS in adults, but we really have very limited data about disease-modifying treatments in children. So our data is mainly limited to small studies that are primarily looking at safety of these drugs. So this is one study that looked at Avonex, Rebif, and Copaxone in a pediatric group. This was done in 37 cases, and it was presented at the AAN a couple of years ago. And they looked at the pre-treatment annualized relapse risk here and the post-treatment annualized relapse rate here, and they found that there was certainly a decrease. The numbers were really not large enough for us to make comparisons between the drugs, but there was an overall decreased relapse rate and a halting of progression of the disease as well. So this is just sort of an overview of some of the drugs that have been looked at least in small studies in kids. And the data here looking at the relapse rate reduction is actually taken from the original pivotal trials that were done with these drugs. It also lists out some of the side effects that we've seen, which look to be very similar in the pediatric population as well. But then it also gives us some of the references from some of the small case series that have been done in kids here too. So there's a recent article that was published about the use of natalizumab in kids, and so this was looking at 15 children with MS, and these were people who had more severe disease. So patients that they included had at least 2 relapses in the year prior, or either a very severe relapse which they did not recover completely from, or they had very active disease with new enhancing lesions on the MRI scan in the years prior. And so the table here is looking at, I know it's kind of small, but it shows you the number of relapses that they had in the year prior. And so for a lot of these patients, they were pretty high. And then they also looked at the EDSS scores before and after. This shows us the number of infusions that they received, and on average, the average was 15 infusions in this group. But following this group out, there was no relapses during the treatment period, and there was no new enhancing lesions on the MRI scans. And again, these are people who had pretty aggressive disease before they went on the drug. And they saw only 3 patients that had new T2 lesions, and those were seen at the 6-month MRI scan. At the 12-month MRI scan that they did, there were no T2 lesions in that group either. Also, the EDSS went from 2.6 to 1.9 post-treatment with this group. So where do we need to go in the future? So pediatric MS, I think it provides us a unique opportunity to study more and learn more about this disease, because these children are presenting at a time where we're very close to the inciting true biologic event. Also, we really need some large multi-center trials to further investigate what are the characteristics of the disease in children and what can we do in terms of moving forward with diagnostic and treatment modalities.